All right, this is a Compass to MS Care program. This is a series by MS Views the News that we've been doing since many years before COVID, where we bring programs around to the United States. And I know this is not truly rural anymore, but I remember once upon a time when it actually was. First time we were here, and that young lady all the way in the back of the room, Susie, made sure that we got here at that time. I do want to thank our sponsors for today's program. So we have Genentech, Novartis, Sanofi, and TG Therapeutics. Let's give them a round of applause because we cannot do these programs without them supporting these events. All right. We also had many displaying today. So we had Alexion and ANI and Genentech, Mallinckrodt, Novartis, TG Therapeutics, and I want to thank the National MS Society who partners with us to do these programs to help us make sure that we're getting people from the community to come to these programs. All right, our presenter is Dr. Max Cararro, and you probably do not need me to say anything about him because you probably already know him, right? That's why you're here.
Beautiful. All right, thank you guys for coming out. It's nice to see you, especially with this weather. I was like, oh, beautiful day outside. We can enjoy it soon. And thank you to MS Views and News for having me be the speaker. Today, we have some sort of defined topics we're going to try to stick to. And I love it because it's always important to know where we're going. So we'll touch a little bit on where we've been, but really this is about what's upcoming, what's new, what are we thinking about in the field, a sneak peek into some of the things that are coming. So this is the agenda for today. We're going to look at the immune system, which is going to set the stage to talk about PIRA and progression. And then what is the deal with treatment options this day and age? What do we have available? What might become available? And how in the heck do we know what is right for an individual? So there's no answer. That's a spoiler. You can listen for 45 minutes and there's no answer. But the most important thing to keep in mind, this is all about you. So whatever crazy terms we are learning and reviewing, treatments we're thinking about, it has to come back to the patient. How might this be applied to you as an individual? So that's really what we're trying to take this information and synthesize it back down to the individual level in clinic with your doctor. So we really have a new focus, thank goodness, zeroing in on progression in MS. And that is great to see. I get this question all the time about reversing agents or repairing agents, or I saw this trial. I do not like to be a Debbie Downer at all. I'm very much sort of the cheerleader optimist type, but we're going to table that conversation for today. There is not really anything exciting in that specific arena at this time, despite what you might see online or get pushed to you on social media. So we're not going to talk about that today. Obviously, it'd be amazing to have options like that. Newer DMTs are stopping over 99% of inflammatory disease. Can't get much better than that, right? What is key to, and we're going to look at graphs for this too, but what's really key to think about is that they can help to delay or even prevent progression. But once progression has started, there's not much they can do for that part of MS. And we're going to look at this again. But that is really a key point. And then because we are still lacking, and that is still a gap in care, that's why we're focusing on progression. What is it? How do we treat it? Et cetera. So as promised, my apologies. Any questions like that? What the heck does that mean up on the slide? DMT is disease modifying therapy, which is the special term because we have to have intelligent sounding terms to make ourselves feel special about every single aspect of care. So that's just treatment for disease. It's not a symptomatic treatment like I have spasticity, so I take baclofen. It's something to actually impact the disease itself. Great question. Okay, so I know this slide's crazy. I tried really hard to find a good one, but we're going to really focus on this. And I know they're not labeled on the slide exactly, but so we used to always call this a T-cell disease. And that's what our initial treatments tried to target. And then people started thinking, well, what if B cells were involved and they were looked as lunatics And since B cell drugs have become available, they've just taken over the market. So those are the anti-CD20 treatments. And there's now 3 of them. You can see up here, this is one of our B cells with a CD20 receptor on it. And here's my laser. So ocrelizumab, ofatumumab, and now ublituximab as well. So Ocrevus, Kesimpta, Briumvi, those are all anti-CD20 drugs. They target that receptor and kill B cells. So there's over 400,000 people that have taken Ocrevus worldwide. It was approved in 2017. Those drugs are incredible, right? They've really been game changers. So yes, B cells are involved. It's really great that we learned that and pursued it because it's made a huge difference. So that's kind of what has gone on. And now we're looking at other cell types as well. The main target is microglia, to some extent macrophages, natural killer cells, and others. But there's a huge push. You can see this BTK towards BTK inhibitors. And so you'll start to, if you haven't already, see and hear things about that. We had a trial report data last year for a drug called tolebrutinib that is a BTK inhibitor, and it was positive for secondary progressive MS. And by positive, I mean it worked. It slowed progression in secondary progressive MS patients versus placebo. So will that drug get approved? I don't know. But it's pretty neat, again, that we are thinking of new targets. And the reason we're thinking about this one is it's very involved, we believe, with, here's more terminology, smoldering disease, or some of those more chronic degenerative aspects of MS. So it's not necessarily the big acute bursts of inflammation that occur early in disease causing relapses like optic neuritis, but it might create some of that slow worsening over time. So if we target those cells, are we going to be able to impact that slow chronic progressive stuff? Those are the questions we're asking. Those are the targets we're looking at. So this is just a little bit about the immune system here. Again, this is the bloodstream on this side. This is the brain, spinal cord over here, and this is called the blood-brain barrier. And it lists a bunch of other prior targets. That's not really the point of today's talk, so I'm not going to get deep into it. But you might recognize some of these other names: fingolimod or Gilenya, cladribine, mavenclad, teriflunomide, Aubagio, et cetera. Good old Tysabri, great drug. So lots of options, lots of targets. But the point of the slide is really we're looking at new things, and hopefully they will be revolutionary like B cells were. Okay, I think this is pertinent to review just because this is not progression, this is different. So, what the heck is a relapse? People ask this all the time. I like to talk about the arc, and hence this really in-depth graphic here. The arc of a relapse, because a relapse isn't, oh, I had this thing happen and it lasted 5 seconds and went away. Not a relapse. Right? A relapse is inflammation. So if I use the analogy of fire, if a fire starts, it doesn't just go from nothing to, right? Something catches fire, something else catches fire, it starts burning hotter, more things catch fire, it increases, et cetera. And eventually that fire is burning, and then it kind of burns out. So you get this arc, right? And that's what a relapse tends to do. Numbness begins in a foot, it feels weird, gets your attention, gets more intense, starts to spread up the leg, maybe to the other leg. So it's growing, right? And then it usually hangs around for days, weeks, months, and then tends to improve to some extent. Hopefully all the way, sometimes not. But that's how the symptoms appear. The technical definition that we use in clinical trials, et cetera, is the appearance of new symptoms or the return of old symptoms for a period of 24 hours or more in the absence of an infection or a change in the core body temperature. That's a lot of words. And it must occur more than 30 days from the last relapse. So that's a technical definition. Pseudo-relapse is the recurrence of old symptoms triggered by things like infection, heat, stress, and fatigue. And then they're relieved by treating the trigger. So early in diagnosis, this is a big concern, obviously, because you just had a relapse, you got diagnosed, you're maybe starting treatment, et cetera. There's a lot of anxiety surrounding this. So when another symptom pops up, it's always like, oh my gosh, is it happening again? Is treatment not working? But it's important to learn about pseudo-relapse because it's not new damage, right? It does not require high-dose steroids. It does not require a switch in treatments, et cetera. This is scary, but you are reliving symptoms created by old prior damage. And they're just provoked by things like infection, hence the definition on the prior slide, where it can't occur in the context of infection. Okay, what is progression? And here's where we really, we don't know. We don't know how to measure it. We don't know how to define it. You could use that old pornography, like you know it when you see it. I've been in rooms with a bunch of other doctors, and somebody might be asking us, well, how do you really know what progression is? And the answer is always, the patients tell us, right? That's how we know. And yet we're trying to measure it in a clinical trial in some uniform, objective manner. It's extremely challenging. So what is progression? In general, it's a slow worsening of disease, of function. That could be cognitive, that could be physical, walking, it could be all kinds of different things, but it's just a slow worsening. It does not occur in this over a week, right? It's just slow. Well, probably last year I started having more difficulty walking, but I can't really say when. And it definitely got worse over the year, you know, and now sometimes I drag my foot a little bit. It's just really slow for the most part. What is smoldering MS? There's argument about this. It's sort of a term used to describe that characteristic. It's not necessarily a technical thing, smoldering disease. But a lot of people like that analogy. I don't mind. There's debate over that too. I don't mind it because I think the fire analogy helps to talk about relapse and what that is. And smoldering is kind of in keeping with that. It's not a big bonfire. There's an ember still burning that won't go out. PIRA, progression independent of relapse activity. This is, again, us creating a fancy term to sound smart. It's basically, you haven't had a relapse, your MRI hasn't changed, but things aren't as good as they were. And so how do you explain that? And how do you treat that? How do you measure that? So how can we target it? How can we measure it? This is very confusing, and it has been so for a long time. By way of example, I could not figure out why that slide was blank. I couldn't get rid of it. It's not in the actual setup. This is 1996 definitions. This is how long we've been trying to explain, understand this stuff, and just look at how messy it is. So don't learn this. It's just here, but to show you this is not easy stuff. We don't know what we're talking about. We're trying to figure it out. For those of you who know me, know I'm going to be direct. I want you to have information. I want to be honest, even if it's not fun, or others we can't get anywhere. So we used to say, okay, progressive disease, you can have primary progressive, where just from the onset, it's always gone, right? You can have secondary progressive, where you had relapses initially, and then it starts to slide. Or you can have progressive relapsing disease, which like, what? I thought progressive wasn't relapsing. And so you can already see where this is not great, but it's describing things we see in a clinic because it's messy. So he said, okay, we need to update this. In 2013, you have these phenotypes. So we said, when somebody has progressive disease, we want the doctors to say, okay, was it primary progressive from onset, or was it secondary progressive after an initial relapse? And then you have to describe it further. Is it active? So whatever you're saying they had, active basically means relapse. It means inflammation. But I thought they had progressive disease, right? What are we talking about? And do they have progression while they have progressive disease, or do they not have progression? Like, it's messy. So you're trying to describe the current state that somebody is in at that point in time, which can change. And so that can be helpful, but clearly that is confusing as all get out. And so it's important to try to define these things so we can think about them and communicate what we're seeing, but it's murky. And so that's the point. You can see all the confusion that continues around this. We're now going back to kind of the beginning where it's like you have MS. If it's MS, it's MS. These are different ways it can present. So RIS, or radiographically isolated syndrome, is just saying somebody has changes on an MRI, but they've never had a relapse and they have never had progression. Maybe they had a car accident, got an MRI, showed spots, and everyone's like, why does that look like MS? You're totally fine. What is that? Does that become MS or not? What do we do with that? So that's one category. This clinically isolated syndrome is basically saying there was an event, there was a clinical event, a relapse. The MRI, interestingly, may or may not show changes. And that's not the point of today's talk, so we're not going to get deep into that. But this is another thing we think about. And then some people have relapsing disease and some people have progressive disease. But we're really just kind of saying people have MS. And what we're trying to describe clinically is what is going on in the body biologically. So sort of the main two categories are there's inflammation and there's degeneration. And that's what we're trying to get at. And we sort of talked about how good the newer drugs are at treating the dickens out of inflammation. Some of the older drugs too. Tysabri's 20 years old, 21. But this we can treat really well. But if you think about neurodegenerative conditions, ALS, Parkinson's, Alzheimer's, we cannot impact those disease courses, to be blunt. They're all neurodegenerative. So when it comes to the degenerative aspects of MS, we don't really know what we're targeting. We can't really treat it specifically that we know of. Some drugs seem to slow things down. And we're going to see another slide in a minute that does provide hope, right? But it's just, we don't even know if we're directly targeting whatever mechanism is causing degeneration because we don't know what mechanism is causing degeneration. There's theories, but none of this is really proven yet. So it's very challenging. But this slide is up to sort of help distinguish those concepts. So it talks about the pre-symptomatic phase and the relapsing phase and SPMS. But what I want to focus on is the red spikes are clinical disease activity, relapses. So this could be an optic neuritis. This could be a transverse myelitis, blurred vision in an eye, inflammation in the spinal cord causing that leg numbness. So that's how the MS can present clinically. This is radiographic or MRI changes. Brain lesion appears. Another brain lesion appears. Spinal cord lesion appears. Who knows what it is, but that's what that represents. And all of those are inflammatory changes. And so you can kind of see this blue line in the back. Hopefully that shows up a little bit. Inflammation picks up at some point. We don't know why. It tends to start to peak around the time of diagnosis. And then over time, inflammation tends to fade away. And that becomes the not dominant feature of MS. So by the time you've had it for 40 years, it is less common to have a relapse, which we're going to talk about later in terms of picking DMT for you. Everybody good on that? So that's kind of the first part of this disease. The other thing to notice is in the background, this purple line, this is a degeneration. And how that just slowly trickles upwards over time. And it is not prominent early on for most people. So there's different processes occurring. Probably they interact to some extent, but it's very complicated. Hence, the focus is really on the degenerative part of the disease that causes progression. I hope that is clear as mud. Or watered down mud. Okay, so that's sort of the big picture biological background to help explain what people with MS might be living, what we see in clinic, what we're trying to treat, how we're trying to design clinical trials, et cetera. Okay, the EDSS. So this is the disability score that we use to measure progression in clinical trials. And what it is it's basically a 10-point scale, and you can kind of see how it's marked out. We take a neurological exam, strength, sensation, walking, etc. And then we use this special scoring system to put it into this and create your EDSS. So you have your disability score. That is the way we have always measured progression of disability in clinical trials. It is inadequate. It's very heavily weighted on gait. It does not take cognition into account. It's missing a lot. So we're looking at other things like the EDSS plus, which includes a timed 25-foot walk and a 9-hole peg test, which we're going to look at. A symbol digit modality you can do is a cognitive screen. There's biomarkers that are being studied. Historically, they were studied in the CSF or spinal fluid. And more recently, we've really been looking at them in the blood. Personally, I believe this would be amazing as an opportunity because as a routine blood draw, you could ideally have information that lets you know who's at risk of relapsing, who's at risk of progressing, et cetera. But we don't have, these tools are not prime time yet. So we're trying. Radiographical biomarkers, we use MRIs, but we're looking at new techniques, things called pearls or cells, which are paramagnetic rim lesions and slowly expanding lesions, which might be markers of smoldering MS and microglial activity. So if you think back to that slide of new targets, looking at microglia, will those impact this aspect of it? And then we should keep an open mind and keep pushing. But we don't even have great ways to measure this. It's the truth. So this is the symbol digit modality test. You have these crazy looking symbols. They're all keyed to a number. And then here you have to take the key and apply it and fill this out. This is a measure we've used for a long time. We try to do this about once a year in clinic. But it's hard. Things happen. Like someone's sick and misses an appointment. And then when they come back in, we're talking about that. We don't have time for this. It's the real world. So it's very hard to get this data every single time or even as frequently as you want. 9-hole peg test. So this is a timed test and you're moving pegs into little holes and then you're picking them back up and putting them from the holes back into the bin. You use with each hand. This is another test that we look at. The timed 25-foot walk is just walking 25 feet and you time it. It's pretty self-explanatory. There's vision charts. We try to use them. We use a standard chart and a grayscale chart. There's ocular coherence tomography or OCT testing to look at the thickness of the retinal layer in the retinal nerve layer in the back of the eye. That could be a surrogate marker for degenerative stuff, but that just has never really taken off. It's not usually an outcome in trials. It's not something that people are getting all the time. But we're trying, but we don't even have great measurements for this stuff. But here's why treatment matters. So to go back to sort of what we were saying at the beginning, time is brain and spinal cord. Plenty of studies show what this graph is indicating, that treatment and diagnosis leads to better outcomes. So the higher you go here, the worse the disability. Delayed treatment, people don't get diagnosed quickly enough. People don't want to go on treatment early, et cetera. They tend to have worse disability outcomes. People who were never on treatment tend to have the worst disability outcomes. So our treatments do help. They do protect people from disability. And then to add to that, we have a quick series of slides after this. High efficacy treatments, these drugs are not all the same. So our best treatments protect you better, right? They prevent brain and spinal cord damage better. So the less damage you have, the better you tend to do. So you see that same pattern there. The early implementation of highly effective therapy makes the biggest difference. That's the number one thing we can do to protect people from disability. This is a timeline of DMTs. Again, not really the focus, but it is nice to see this progress. So the first one came out in 1993, right here. This timeline does not even include, it just goes up to 2021, but 2022, you had Briumvi. 2024, you had Ocrevus Zunovo. And then will we see one of those BTKI drugs this year? And if so, will it be for who knows what? Secondary only, all forms of MS, who knows? So there is progress. But because of that slow trickle timeline, we used to not have treatments which stunk. Then we had injectables, and it was really the age of, you can do it, just keep going, even though it was brutal. And then it was like, well, there's only one relapse, so we don't have a lot of other options, just keep doing it, or we'll change you from one interferon to another. But that's what was available then. And then it was like, well, maybe we should start switching people if the treatment's not working and be a little more proactive as much we can. And then we started getting these really effective therapies. And it's like, well, what do we do with this? Do you start with it? Do you have to escalate to get your way to that, et cetera? This was a huge debate for a very long time. That is no longer a debate. Even in my career, that's no longer a debate. Everyone's like, yeah, the earlier you protect people with better drug, the better they do, of course. And now we have these new thresholds like NEDA, which is no evidence of disease activity. What that is saying no relapses, no confirmed disability progression, so the exam is staying the same, no gadolinium enhancing on MRIs, no new or enlarging lesions or T2 lesions on MRIs, and then no worsening of brain atrophy, brain shrinkage. So all of our brains shrink over time, and with MS, that can be sped up. That is also something that's really hard to measure. They have quantitative tools you can get now, these MRI packages, where software will calculate the exact volume of the brain, but those are imperfect. You could get one in the morning and get one in the afternoon, and it gives you a different read. Your hydration status can impact it, et cetera. And they're expensive. So not many places are just getting those routinely, and especially the cost is sometimes passed on to the patient. You pay your MRI copay, but you may have to pay extra just for that portion. And as you know, it adds up. This is not an inexpensive disease. So it would be great to have that on everybody all the time, but we don't. Almost nowhere does. So even though this is an awesome target and it's trying to say, we're thinking about all of it, we don't want any of this to occur for any patient, we can't even get these measures routinely on everybody. But at least the goal's there. At least our treatments are giving us, think about, again, that like going from no treatment. Think about that jump over the last 30 years. It's really impressive. So we want this to keep going. So the next frontier, that's kind of where we've been, what we're thinking about, how we currently measure things. Next frontier is how do we sequence, in my opinion, I think this is not discussed enough, how do we sequence our treatments to protect against MS, but also keep people safe long-term? We have not had, our initial treatments weren't really immune suppressants. So now we have drugs that can be more immune suppressive. What does that mean long-term from a safety standpoint? So how do we balance those things? There is no standard for this. People really don't discuss it. I mean, to me, this should be front and center right now. Yes, we're thinking about advancing treatment progression and stuff like that, but we need to think about what we have now. How do we use it? What does it mean long-term for safety, not just efficacy? So in most cases, like we just saw, we want highly effective meds. And I would like to debunk this instinct that people have that the better the med, the more risky it is, because that's not true. Those do not go hand in hand. Some of our moderate efficacy meds or moderate to high efficacy meds can have some of the most risk, especially long-term, and especially if they're not monitored properly. So that's part of this too, is really being proactive with treatment, getting on the best thing you can as early as you can. making sure it's working and making sure it is safe for you as an individual. So that's one factor. How do we proactively and accurately monitor for safety? Lab tests. Almost every drug requires lab tests. Most of them every 3 months, sometimes every 6. And it is crazy. Sometimes I'll inherit people who have moved or whatever the case might be. There's no labs, not even from a primary care doctor. And somehow they're still getting treatment prescribed. And it is scary. If your lymphocyte count as a type of white blood cell is in the gutter, and who knows how long it's been like that, those cells are supposed to be going around surveying for infection, surveying for cancer cells. It's a big deal if there's a problem there and it's not being monitored. So blood work is critical. I know it can be a pain in the butt, but this is something to really hammer home. Like, this is just the game. This is how we play this game. You have to get the safety stuff done. So personally, I'm nuts about this. If it's that box is not checked, meds are not prescribed. It's just too big of a deal. And I know it's hard. Like, life is busy. We go through it. But the stakes are too high. It's really critical. So this just has to be good communication with your doctor and a good plan, but it matters. It makes a huge difference. So labs are huge. Infection reporting. So if you go to the doctor and they say, "Hey, how you been?" You say, "Oh, I'm good. I'm good." And that's it. And then turns out you've been sick 3 times since your last visit. We need to know that, right? That could be a marker of the drug making you immune suppressed. Everybody gets sick. I mean, this winter has been terrible for people. But if you're getting sick out of proportion to your peers or in weird ways, like, well, the sinus infection required 3 rounds of antibiotics. That's not normal. And then turned into a pneumonia. That's not normal, especially if you're 40. So report that stuff. And I don't think we do a good enough job communicating that. We need to know, because it could mean the drug is making you abnormally suppressed. And we do not want that to continue. So a lot of this is communication in the office. I can't emphasize that enough. So we try to always really nitpick that in clinic, like, "How's it going? Have you been sick?" But that's something to think about between visits, because of course you're trying to just flow through it. Maybe you have to go to the urgent care, maybe it's your primary care, and get back to your life. But we need to make note of that together. It would be great to simplify reporting to the FDA, but this is another feature, especially as new-ish drugs are on the market. We do 2-year clinical studies, which is not a super long time. So how do you know the longer-term implications of those treatments? And so to encourage everybody here, you are allowed to report directly to the FDA. You can report directly to the manufacturer of the drug as well. But I would encourage that. And it's not that cumbersome, but it'd be great if there were, this day and age, just an easy button. But you are empowered to do that. And I would encourage it, because we're pretty vigilant about that. But it's just, the more we have those cases, there was one in California, there was one in Nevada, there was one in Texas, of whatever it might be on a new drug, then it starts to come to attention. And that's why these drugs have label updates over time. Oh, now we learned we need to screen for such and such blood test, or that if somebody has this symptom, you need to be on the lookout for X, Y, or Z condition. So that can really help. So that's kind of secondary a little bit. But just keep that in mind, especially if it's something really abnormal on a treatment. Getting a cold, okay, talk to your doctor. But if it's a cancer, if it's something weird with the colon, or an abnormal infection where the doctor's like, "Who in the heck gets this?" Reportable. And that's something you can do as well. Okay. I think we kind of have hit this point already, and hopefully you appreciate that is a real challenge. But MRIs, visits, so doing the exam, et cetera. But part of the visit too is being honest and talking. Is work more challenging than it was for cognitive reasons? Is it more challenging for fatigue reasons? Talk to us. And if you don't have that relationship where you can really, have people record that and report it and take it seriously, you may want to find somebody else where you can do that, because it really matters. And like we said, for how do you know who's having progression? If you ask a room of MS specialists, the patients tell us. So those conversations matter. So we need visits, we need exams, and we need a good open relationship and communication so we can figure it out together. Biomarkers, I'll just touch a little bit more on that. There's different ones that are available now commercially. There's some you can get through LabCorp requests, Mayo Clinic. There's a panel from a company called Octave that has their own, it's like 17 markers or something like that. But they're not widespread in use yet. They're not standard of care yet. My personal preference and opinion is that I think it is worth having a baseline set of values, because there's no reason to think they won't be important. And so if we have a baseline, if we decide down the road, you know what, we really should start using those biomarkers, then you're ahead of the curve. We already can know what you were like in 2024 and 2025 whenever you have it done. And we can have something to compare to in 2027 to see, is it different than your baseline? So I like to get a baseline on every single patient. That's my personal opinion. Again, I would rather be proactive. There's not much to it. It's a blood draw. There can be an out-of-pocket cost. It's usually, people complain about MRI cost all the time, rightfully so. I have never had somebody complain about the biomarker cost, which is great. So that's my personal opinion, is I like to get them. I think, why not get a baseline? Try to stay ahead. Okay, how to manage disease-modifying therapies in older patients. So these trials typically are cut off at age 55. If you're 56, you are not in a clinical trial. So we don't have data on 65-year-olds and 75-year-olds, et cetera. What we do know is that the immune system tends to get weaker as we get older. So if you have a less robust, less strong immune system, and we're giving you one of these drugs that can be immune suppressive, clearly it could have more potential risk. We also looked at earlier how that curve of inflammation starts to die off. So the risk of a relapse gets less over time. Therefore, you may not need a treatment as much as you did when you were 25. So the potential benefit of drugs tends to go down over time. The potential risk tends to go up over time. And that's really the points you need to think about. There's no cutoff age. I don't know why people need things to be black and white all the time. What if you're diagnosed at 65? What if that's when your disease gets active? Do you not take treatment? You're having tons of inflammatory activity. You should go on treatment. So there's no cutoff, but you're just constantly saying, okay, now it's been 6 years since a relapse, 16 years since a relapse. What are we doing? Do we still need you on whatever med you're on? How's the risk of that med looking? And the safety becomes more front and center. So that's a topic we need to continue to think about. But people always want these like, oh, it is like this. This is the way it is. It's much more fluid than that. Every case is different. You guys have heard this over and over. They call it the snowflake disease because every individual case is different. And it is different at different points in time. We might know your MS at age 30 and it's going to be different at 40. It might be different at 32. So we need to always be thinking about things in a fresh way. Here's a couple interesting topics going around: extended interval dosing. So can you give drugs less frequently, depending on the product? Exit strategies for drug. Are there certain treatments you can take to get you off high efficacy drug? Are there certain drugs? So, you know, I don't want to get into specifics really, but Mavenclad, for instance, is a drug you take 1 year and the next year, and then that's all you're supposed to take. So theoretically, you could use that and not need a drug again. So people call that an exit strategy from disease modifying therapy. There's different thoughts about this, but it's just important to be thinking about it, to be discussing it. So those are some of the ways we think about managing DMTs in older patients. And I mean, nowadays, there's so many people who are super active at 65. You know, so age is nothing but a number. It's different for everybody. And then this, oh boy, this again, you see it keeps sneaking back in there. It's critical and it is tough. So we looked at these different ways, maybe biomarkers. There are currently no biomarkers proven to measure disability. We're looking at things like GFAP, but we don't know yet. Same thing with radiographic biomarkers. We don't know yet. They're under study. We're trying to get better and better data, but it is tough. So that is the end of the formal presentation. Thank you guys for listening.
Thank you. Thank you. Can you please answer a question that was asked about why are doctors cutting people off at 60 years old from using their medications just because they're showing stability, but maybe they are stable because they have been using those medications?
Yes, exactly. And I always say that's like the devil in MS is, well, do I really need this drug because I'm doing pretty well? It's like, well, you might be doing well because of the drug, you know? So it is tough. We can't be, and I think this goes back to, again, needing more measurement tools. And I hope biomarkers can help with that too. They can look at disease stability from an inflammatory standpoint, your risk of relapse. So if you were to stop drug at some point, you could always repeat those and see if they're changing. And hopefully, because we don't know, hopefully for you as an individual, that will be telling, that will be helpful in monitoring your risk over time. If you were to do something like stop treatment because of age, stop treatment because of pregnancy, whatever the case may be. But there should be no cutoff. Again, I'm this age, I need to be off drug. That's too black and white.
Great, thank you. Next question is from out here.
I don't remember, but that's part of the MS. I know. No, but I do have questions about the Murdoch study is around here, and I think they do biomarkers. Do you know anything about that? And fatigue, have you found anything that really works for fatigue? Those are two of my questions.
Okay. The Murdoch study, I believe, is all through Duke. And that's something that you could contact them for and be registered in. And they do a lot of different things as part of that study. But yeah, they're trying to find ways to monitor and measure over time. So that for people willing and able to do that, that's great, because the more data we have, the better. Fatigue is a very tough one. The first thing is cleaning up. You know, are you on meds that are sedating? How's your sleep? Sleep is, honestly, how's your stress level? Stress is a killer. Everybody just brushes it off. Well, everybody's stressed, or everyone's got a jerk boss, or whatever it is. Stress will take you out. Stress makes people feel horrible. We will dig into fatigue. We'll dig into this burning pain. We'll dig into all these things for months. And then somebody comes back looking great. And I'm like, what happened? I quit my job. All the time. I mean, it is funny because it's sad, but and what can you do but laugh? But it's true. And I think stress is so, it's so important, and people blow it off because they're trying to push through and live their lives, but it's critical. And so I loved Jessica's talk, and especially saying, take care of yourself. It matters. And so many people are saying, well, I got these kids and my spouse or my parents or whatever it is, but you have to take care of yourself. And of course, there's tougher moments, but stress is a big problem. So I would answer, yeah, there's stimulant meds. You could take coenzyme Q10. You could take L-carnitine. But unless you're doing those other things, I hate drugging our way through a situation. So I guess that'd be my answer.
I heard you mention transverse myelitis. I was first diagnosed with transverse myelitis. And of course, there's nothing they can do for that. 4 years later, I got the diagnosis for MS. How often does that happen?
So this is what, it's good to know these terms, and it's very confusing too. Transverse myelitis literally just means inflammation in the spinal cord or across the spinal cord, but it's describing a relapse. Some relapses you don't really have a description for. But like optic neuritis is inflammation of the optic nerve. Sometimes that's a part of MS, sometimes it's not. So it's important, no matter what the relapse is, transverse myelitis or otherwise, to determine is that part of MS, because sometimes transverse myelitis can occur just on its own and nothing ever happens again.
All right. Question from back here.
My goodness. So I feel like our area is starting to experience a little bit of a shift in specialists. And to me, it's a little bit alarming, actually quite a bit alarming. Like some of our specialists will be closer to retirement age, some have already left, moved, et cetera. As an insider, as a neurologist to MS specialist, do you feel hopeful about that in this area? Or what could you tell people and people that are going to be looking to find a new neurologist in the next couple of years?
We have two youngish, affable, eager, and available doctors, Dr. Elias and myself, who are at Piedmont Healthcare. I'm not trying to put a plug, but in all seriousness, we do. And he practices out of Huntersville as well. I don't know if this is a permanent thing. I will be going to Hickory one day a month, starting in April, May, and trying to expand some of the access, but we don't plan on going anywhere. For those of you who know us, we are happy to work people in because we understand it matters. And so I don't know how to answer the question at other places because I was at one. So I don't know. It's tough, but that's a theme in medicine overall.
And neurology shifting, retirements, et cetera. So, and I would imagine that everyone here has a sense of that or understanding of that as well. So thank you.
So those that are professionals online, including Jessica standing here, you could contact CMSC, the Consortium of Multiple Sclerosis, to see what they've got for up and coming of who they have in the medical field that might be looking to enter the space in certain regions around the United States. Okay. All right. We have a question back here.
Excuse me. I'm on the first rung of this ladder of chasing the autoimmune system problem, MS, Parkinson's, whatever it could be. I appreciate your candor in that how difficult it is to plot all of these particular problems. My question would be, as I try to do my own research and kind of figure out where in this matrix I've got this pain, that pain, this problem, I'm stumbling, I can't remember. Is there a comprehensive overview or chart of the various problems? And if you have this particular thing, it could qualify for these three problems, but how we eliminate and get it down to more of a point is by looking at this chart and checking off these 10 things. Is there anything out there that helps you define which direction to look in? MS, Parkinson's, et cetera, all of these things. Is there, or are we just kind of like you shared here this afternoon, I won't say swimming in it's like, if it walks like a duck, quacks like a duck, it should be a duck, but we don't even know if it's a duck yet. So is there an overview that helps
Not really.
the layperson understand where to go?
There's no, I don't know of some comprehensive thing because, as you can see, we sometimes struggle with it. The good news for MS is that there will be lesions. So if your MRI is clean, you can look elsewhere. But obviously that doesn't mean nothing's wrong. It just means you can exclude that diagnosis. But yeah, it's tough.
Got two questions, if that's all right. So the first one's just about demyelination. And so we know that it happens on the brain and spinal cord, but is there any evidence or knowledge of demyelination on like peripheral nerves?
This is considered to be a central nervous system disease, so brain and spinal cord. It should not cause anything peripherally. I did one time read an article about MRI neurography, where the MRI can do specialty looks at the peripheral nerves, and it showed there could be some demyelination, but I've never seen that repeated. So I think the answer would still be just brain and spinal cord. Did you have a second question? Yeah. Okay.
So you started off earlier talking about depression. And I was wondering if there's any kind of clinical way to tell the difference between MS-caused depression versus MS symptom-inspired depression.
Very good question. I think that's almost like the diagnosis and tracking progression. It's tough. You just got to dig in there, probably try out a couple of different avenues to figure it out because it's not always obvious. We try to manage that stuff ourselves. And if it's complex, then the same way I would say you should really see an MS specialist, I would say you should really see a mental health specialist to help us tease that out. But a lot of it is trying to work. I think one thing in general, when people are diagnosed, on average, it's like a year or two, sometimes more, to really accept it, get your head around it. But I always think about Lieutenant Dan coming out of the storm where he makes his peace, and it's just, I'll walk into a room and someone they just feel different. They have a different air about them, and they'll say, I don't know. I have MS and I'm living. And I finally came to that, So initially I think that's a big thing. And that's just grappling with all of it, like any sort of grief processing. But once you're in the thick of it, it's tough, especially if you do have a lot of symptoms. But there's no clean way to know, no easy button for that.
I got some great news for you, though. A week from today, we're doing a program in Miami, and our second presenter, it's a wellness summit. Sorry, it's a wellness summit, but our second presenter is a psychologist that works with MS patients, and the topic is depression and MS. Okay, so if you could tune in online, you could watch the virtual program, and then you'll be able to ask this question online if you want as well. Okay, question for you.
I've heard some recent data that the mean age of MSers is now in the 50s. And how do you, or how does anyone discriminate whether it's aging or MS causing decreasing symptoms or abilities, rather?
So to add to all that conundrum, like we were talking about, aging is not easy, and our bodies wear out in many different ways, cognitively, physically. Muscles shrink, bones degenerate, which makes you less able. So how do you tell? It's very challenging to say, is this aging? Is this MS? Is it sort of accelerated aging because there's decreased function to start? So you can decompensate faster. If you aren't able to go for brisk walks, for instance, as you age, as bones thin, as all the rest of it, if you're not able to keep using those muscles or they haven't been kept strong for years, the decline might be more precipitous, might be more noticeable. So is that specifically the MS causing degeneration, or is that more of a deconditioning? It's tough. Spasticity makes it challenging. Spasticity is really frustrating, especially because it fluctuates. Some days, some moments are worse than others, and it can completely impact your ability to use muscles in a limb. So that's another one that can really make those waters muddy, but it's hard to say. And that's, sorry to keep rambling. That's a big problem because you want to identify progression quickly so you can try to address it. And it takes time.
All right. First question is, are the physicians and pharma companies discussing options for when drug subsidies run out at the end of 2025?
Honestly, it isn't. It's just an ever-present issue is getting coverage, keeping coverage, getting, patient support, et cetera. It is constant. I just did a peer-to-peer yesterday because someone changed insurance and the insurers, well, you can't have this med anymore. It's like they've been stable for 8 years. What are you talking about? So battling those battles is just every day. They're ever changing. They never are reasonable or rational. So we kind of take it as it comes.
Okay, thank you. Next one, are there any DMTs for people with primary progressive multiple sclerosis that do not affect the liver?
Ocrevus is the only drug approved for primary progressive MS, and it does not seem to affect the liver. We check it, but I've never seen an issue with that.
Are there any medications in study for primary progressive MS?
Yes, the BTK inhibitors are in study for primary progressive MS. That's the main one.
That's correct. Next, the other company that you mentioned for biomarker testing apart from LabCorp, can you please repeat?
Octave, like on a piano. Octave.
Octave.
I used
All
to
right.
say octave, and then they were saying octave.
They
Yeah.
do. They do, but nobody understands it. So I just always
Say
express
octave.
it. Yeah. Are biomarker tests and genotyping tests done for the same reason?
Genotyping is very different. So the biomarkers are just things in all of our bodies that the levels can fluctuate over time. So those are very separate.
Okay, thank you. Next one, next one, not delivered or, okay, next one, we're going to say, could you please tell us a bit about ongoing drug trials for both frexalimab and now starting up in a few places for CAR T?
Yes, frexalimab is another drug with a new target that affects multiple cell types, T cells, B cells, macrophages, microglia, et cetera. And the goal is to inhibit function rather than kill cells. And it's being studied for progressive and relapsing disease. We're actually in those trials. We're doing both the SPMS and the RMS trials for that. So it's exciting because on paper, that all makes sense. They also had a very strong phase 2 study. Their data from that's very good. So that phase 2 is for only relapsing disease. The phase 3 trials are bigger and they're side by side, and they're doing 2 trials looking at relapsing, and then they're also looking at secondary progressive. And the CAR T is interesting. It's kind of been looked at before to a smaller extent, but I believe it's a new company that is looking at this in a new way, and hopefully that will have impact as well. That's earlier on, though. I think that's just phase 2.
I'm going to tell you a little bit more about CAR T. And I only can tell you about it because we interviewed the top doctors from Bristol Myers Squibb on their studies on CAR T. So there's an interview that you can watch on our YouTube channel. It's called Breaking Barriers that I did with these 2 doctors. And you can learn more about the CAR T therapy right there and why it's being used and what they're hoping to get out of it. But it is all in clinical trials right now. And Bristol Myers is not the only one. Some of the other pharmaceutical companies are looking into it as well. It's to kill the T cells, correct? And they used it extensively. It's being used currently with people with different forms of cancer. And they're actually finding that when they eradicate certain cells from the body, it's all cellular therapy. When they eradicate those cells from the body, it's getting rid of the disease. So one of the doctors that were part of the interview actually had it done on him to help him with some kind of cancer that he had. And he lived through it, and he's doing extremely well, and he has no more cancer cells in his body. So that says something about it. So we'll see, though. See if it has something to do with multiple sclerosis. Sorry for stepping on you over there, but I have to throw in my 2 cents every now and then. That's why I do what I do, all right? All right, next person writes, how does coenzyme Q10 affect fatigue?
Coenzyme Q10 is an over-the-counter supplement you can get with really no downside. So it's sort of one of those things like you may as well try that first. We use it also to help prevent headaches and migraines. We think it helps with fatigue by helping to create more ability for mitochondria, but who knows?
Okay, thank you. I'm going to take 2 more and then I'll come out to you all, okay? All right, first one is, what are your thoughts on the JCV patients, JCV positive patients with a lower below 0.9 staying on Tysabri for greater than past 2 years?
So Biogen makes Tysabri. They cannot talk about this data, but it's there. I don't know why they can't talk about it. It's ridiculous because it would help inform safety, et cetera. If your JC virus antibody is less than 0.9, I call that JC virus favorable. So there's negative, positive, whatever, but it's confusing because you can be low positive under 0.9 and still at low risk. So I just say that's favorable, negative's favorable. So if you're in that good position, your risk of disease, even 6 years on treatment, your risk of PML is about 0.05% over a 2-year period. That's really low. You don't have to stay on it, but in my opinion, that's a comfortable risk. And it's really the patient's choice at the end of the day. But for us to not provide that information when it's available is crazy. So if you are low positive, which is the question, or JC virus favorable, you should be able to stay on with a low risk of PML. And you can also use extended interval dosing where they do 6 weeks instead of 4, and that will drop your risk as well. There's newer data, but certainly over 90% decline in your PML risk by dosing every 6 weeks without a seeming drop in how well the drug works. So plenty of ways to keep people safe, much more than 2 years with a low positive JC virus status.
Thank you. Next one, and then I'll go back out there, and then I'll come back here because there are more online. But speaking about Tysabri, person's asking about the biomarker. I mean, excuse me, not the biomarker. I forgot the word for it. Yeah, but what's the word for it? The biosimilar. There you go. Thank you. I must be tired. All right. Yes. So can you tell us about the biosimilar for that and why it's not yet on the market, even though it was FDA approved?
In my opinion, every time a drug goes generic, it is bad for patients for a lot of different reasons. So this is not a generic because it's an infusible biologic drug. It's a biosimilar to Tysabri. But Tysabri, they have, again, this drug's around 21 years. They have their own JC virus test with well over a decade of data. So everything I just quoted, those numbers, are from Biogen having numbers on their patients, on their drug, on their test, with their JC virus test. This biosimilar drug has to create their own test. They have no track record. It's a different molecule. It's similar, but it's different. Why? I mean, I don't want to play with that fire. That's crazy. But so I think they're encountering a lot more difficulties than they anticipated. And personally, I'm like, I don't know why you'd try to mimic Tysabri. Like it's had a long history and its own drama, especially so for Tysabri, there were no cases of PML in the trials. Came to market and we saw PML and it got pulled back off. So it has a long, intense history. And then they worked really hard to say, yeah, but this is the only highly effective thing we have. We got to figure out how to keep it safe. So they said, just use it for 2 years, right? And that they don't seem to happen in the first 2 years. Then they made the stratified JC virus test and they started trying to get education about that out. They have all this groundwork laid to help us feel comfortable keeping people safe on it. So to try to jump in that space with a different drug, with a different test is, I don't like that risk. I don't like, why do we need to rock that boat?
Going further with that, they are using it outside the US where there is no FDA. So are there any numbers out there on who's getting what and possibly something negative, or is it showing great use outside? And one of the things in England, they're actually using it as an injection now, not an infusion.
I do not know any results from it, real world.
You're on.
Okay. I have been on the same drug therapy for 3 years. I have developed trigeminal neuralgia, occipital neuralgia, drop foot on my right side, and there hasn't been any change to my therapy. So what I'm asking is, do you look at the actual person and what they're going through and decide, oh, you're progressing, or is it you just watch the lesions and say, oh, there's another one, so you're progressing?
You have to take it all into account. Yeah.
And so another thing that I was thinking, if you are not doing better on the therapy that you've been given, and you've spoken about that to your provider, having done all the tests that they require, what do you do in that situation? Should you find another physician and get a second opinion, or?
Yeah, I mean, I think in general, if you're not comfortable with something medically, you get a second opinion.
I really think that they're missing some things, and I mean, that's just my opinion, but I feel like I've been progressing, and it's just.
He can't answer questions about you, though. Right. So that reminds me. So if anybody has a question about yourself, change the question to make it more general so he could answer the question.
I wanted to know if there was any development in the beginning of the onset of the disease, like maybe prevention entirely. If you're looking at that there's a genetic component to this, what can we do for our children? Like what is there any new data in that area?
The best thing for kids is keep the vitamin D up, keep them active and not obese. Keep them, have run around outside, all this stuff. Have them eat clean, keep them generally healthy. Yeah, smoking and secondhand smoke exposure, horrible for kids and their risk, but they don't need like MRI screening. Their risk is increased relative to having parents without MS, but they still have a 97 to 99% chance of not getting it. I hope there's more. There was some initial talk a few years ago about vaccine against the Epstein-Barr virus, which is extremely technically challenging to make, but that would be awesome because theoretically that could prevent disease.
Before you guys talked about CAR T, you were talking about there was study phase 2 and it didn't kill the cells, but it was inhibiting the cell growth. What was that? Was that a med?
Yes, it's called frexalimab.
Can you spell it?
F-R-E, I'm a terrible speller.
Me too. Just a general idea.
F-R-E-X-A-L-I-M-U-A. Sorry.
A-L.
Sorry. M-A-B. Frexalimab.
So when your B cells start to tank, what do you do to boost them?
Your B cells?
Yeah.
On a therapy or?
Yes, on a therapy.
Well, so certain drugs are designed to kill B cells, so that would be a good thing. The anti-CD20 drugs, Ocrevus, Kesimpta, and Briumvi. Every drug works differently. Some drugs should kill B cells and make your count 0. Other drugs should not do that.
A person says that it's been recently announced by an organization that people with MS do not get Alzheimer's.
This is coming up in the news recently. Yeah. I I don't think they're at increased risk, but I don't know that I've seen any convincing article to say you won't get Alzheimer's if you have MS, or you will get Alzheimer's if you have MS.
Okay, next one. Let's see if you can answer this. How can a woman who has MS and is also going through menopause tell which one is trying to and ways to deal with the MS symptoms that mirror menopause symptoms?
I have an excellent group of OBs that I use that they sort of specialize in hormonal aspects of care, and they are great at helping to tease that out. That's personally what I do.
Okay, thank you. Next one. What about us older MS patients who never had any drugs but are steadily getting worse? What options might there be?
It's important to never underestimate the sort of rehabilitation side of treatment and care. So PT, OT, speech, personal trainer, whatever it might be, but just making sure that you are optimizing your nutrition, optimizing your body to perform well or as well as it can and hopefully improve. So that would be the focus probably.
Okay, thank you. Next one. Person writes, I think I heard you say as you get older, you don't have as many relapses. If so, at what age do you think the relapses stop or slow down?
So my job is to never trust MS. And even though I showed that graph and said, yeah, things die out over time, I'm always on the lookout for it. I have seen, quote, stable 73-year-olds relapse, enough that I'm always on my toes. So you can never go to sleep on the disease as the provider. You always have to be thinking about it.
Okay, thank you. Next one is, what comorbidities are most likely to appear with a person with MS?
I don't know. But the standard, especially in America, the standard stuff, we're always making sure we actually have a form that says, I'd love to be a patient here and work with you, and I'd love to be your doctor, but you got to have a primary care doctor. Because we need to keep the general health up as well. They tie in together. Diabetes is toxic to nerves. So why have the opportunity for more nerve damage when you have a neurodegenerative condition, et cetera? So we're trying to keep overall health optimized.
Thank you. Next one, I don't understand, but let's see if you do. It's not the active but progression, the same as pseudo-relapse. It is not the active but progression.
No, pseudo-relapse is its own thing. I'm not sure if that's the question, but pseudo-relapse is a short-term thing. Let's say somebody has a UTI, their vision gets blurry because they had an old optic neuritis and there's damage to the optic nerve. And then they take Cipro or Macrobid and the UTI gets better. And then their vision goes back to how it was.
In your area, how many clinical trials are there for people that are 50 plus?
So 50 is still in the inclusive range. Usually 55 is the cutoff for a relapsing trial. And thank goodness they're starting to extend the age for progressive trials to 60. I think there was one that was 65.
Can you tell people, please, why they stop allowing people to do clinical trials when they reach a certain age?
One, relapses are less likely. Two, comorbidities are more common. And aging has its own set of issues. So it gets more complicated to tease out, was that the MS? Is the drug working? And it gets muddy. So if you want to spend $1 billion running a clinical trial and getting data that makes it worth your while, you have to draw a line somewhere.
All right. The last one currently from online is asking, what do you recommend for people who live outside the metropolitan areas that need to see doctors or be able to get medical care but cannot get to the metropolitan areas?
We had virtual visits. Those were awesome. The clause for that expired at the end of the year. They did a 11th hour. Okay, we'll extend it 3 months. But that seemed really rushed and questionable. And who the heck knows what's going to happen with anything? So I don't know if those continue. The way that our policy was you had to do a once a year in-person visit and the others could be virtual. Hopefully those are here to stay, but currently they're not here to stay. But that was great.
Okay. Question here.
Yeah, I've heard that Epstein-Barr virus and MS are kind of linked somehow. I wondered if you had anything to offer a patient like me who has both. I've been diagnosed with chronic. I'm just okay. Anyway, is there therapies for people like me that treat both?
There's no treatment for Epstein-Barr virus. The other thing, if you live remotely, is to try to find a solid local neurologist who you can use most of the time, and then have a specialist in your back pocket for tough questions, for visits once a year, something like that, just to try to make it more manageable.
That was one thing I was going to bring up, is how important it is to see a specialist, not just see a normal neurologist, but see a specialist like this doctor here. I have a question about UTIs and Rituxan. Are there ramifications or issues with some meds that affect you, not make you, but cause you to have UTIs?
Yes. So that's a nice individual example, but I would broaden that out and even say it is important to look at everyone as an individual on each individual therapy. You may be on something that's typically not, you typically don't see a large number of increased infections, but that person has them on that particular therapy. Who knows why? So then you probably want to switch therapy, and maybe in the next one, you will not have that same increased risk. So it's important, like we were talking about those visits and asking those questions and reporting. If you have one UTI in the last 10 years and all of a sudden you have 10 in 1 year, that's a problem. So we need to figure out, is that the drug? Did something else change? But it could be Rituxan. It could be any number of drugs, though.
Okay, thank you. And let's thank the doctor for speaking.
Thank you, guys.
All right. Thank you. Go to our website, check out all the programs, virtual and in person, that are happening, and just keep on learning and living. Okay. Thank you. Bye-bye.